Hello, my name is Dr. John DeWitt, and I am Associate Professor of Medicine in the Division of Gastroenterology in Indianapolis, Indiana. And I have the pleasure of discussing an article with you, which has been accepted for publication into GIE. The article is entitled Treatment of Esophageal Leaks, Fistula, and Perforation with Temporary Stents, Evaluation of Efficacy, Adverse Events, and Factors Associated with Successful Outcomes. This study was a retrospective review of a 9.5-year period at our institution where we looked to see how successful and factors associated with successful outcomes of patients who underwent temporary stenting for leaks, fistula, or perforations. And for this study, we defined leaks as those that were postoperative following esophagectomy, usually for cancer. And we define perforations as those that were either iatrogenic, such as following endoscopy, or those that were spontaneous, such as Boerhaave syndrome. And we define fistula as those usually associated with inflammation or infection, such as sarcoidosis or mediastinitis. Another important definition we defined was primary closure versus secondary closure. Primary closure was that associated with efficacy with the first stent, and secondary closure was that associated with one or more stents. What we typically did was we placed a covered or partially covered stent in these patients. The choice was really up to the endoscopist. In general, we tried to use partially covered stents in those patients in whom migration may have not been something that would have been beneficial. And we chose fully covered stents generally in all other patients. The size was at the discretion of the endoscopist. Generally, we placed smaller caliber stents in those with strictures and larger stents in those with normal sized esophaguses. The endoscopist then brought the patient back, usually within about a 4 to 6 week period of time, for those in whom a partially covered stent was placed to remove, and then a fully covered stent. Generally, the patient was brought back about 8 weeks later. And what we did was we performed a univariate analysis of those factors that we felt to be potentially important to see if any predicted those in whom successful treatment was achieved. So for the study, we found 67 patients in whom over 130 stents were placed. We excluded 13 patients and ended up with a population of 54 patients in whom 117 stents were placed. Of those 54 patients, 29 had leaks, 15 had fistula, and perforations were seen in the remaining 10. Technical success was found in 100% of patients, that is, placement and removal was successful. 2 patients required plastic stents for eventual successful removal of the initial stent. What we found was that 40 of those 54, that is 74%, had successful primary closure. An additional 5, or 45 out of 54, or 83%, had successful treatment after the second or more stents. So an overall successful closure was achieved in 83% of patients. Successful closure was defined as resumption of food and or radiographic confirmation of closure. What we found on evaluation of complications, we found that of those patients with short-term follow-up, which was all 50% were asymptomatic, but the additional patients had complications including migration in 28%, which has been reported by other authors. On univariate analysis, we found that the shorter time between diagnosis and stent placement and the smaller the fistula or leak or perforation opening, the more likely a successful closure was achieved. So what does the study mean in practical terms? I think there are three important points. Number one, endoscopists who see these patients need to feel comfortable with both stent placement and removal. Partially covered stents are more complicated to remove, often require peeling away tissue overgrowth, but eventually these stents are almost always able to be removed with some work. Typically we use a single channel 1T scope With alligator or rat tooth forceps, very rarely do we require a 2T scope with two alligator or rat tooth forceps to remove these stents. Second take-home message is obviously these patients need to be triaged to endoscopy as soon as possible in order to undergo stent placement. Obviously, the smaller the opening, the more likely the successful closure, but if these patients have diagnosis delay or treatment delay, our study seems to indicate that these patients may have a less likely beneficial outcome. The third takeaway message is even though 83% of patients were successfully closed, there are a small minority in whom closure is not successful. And future studies with new devices such as larger through-the-scope clips, over-the-scope clips, or perhaps suturing devices may be able to aid those patients in whom there may be a delay in diagnosis or a larger opening than we were able to achieve in our study. I thank you for your time. If you have any questions, you can feel free to email me at jodewitt@iupui.edu. Thank you for listening.